Good morning, everyone. Let me briefly tell you about my PhD thesis. I'm working on novel therapeutic approaches in sleep-related breathing disorders. My name is Bardóczi, and I'm a pulmonology resident in the Department of Pulmonology at Semmelweis University. And I chose this topic because during my work, I meet many patients who are suffering from obesity-related sleeping disorders, which destroys their quality of life. So I would like to improve on that. And our research team working to find the best therapy to reduce the symptoms and the severity of the disease. As you can see, we are working on two specific projects which address to this problem. My first project is investigating the effectiveness of GLP-1 analogs in obstructive sleep apnea patients, which is a systematic review and meta-analysis. Obstructive sleep apnea is a serious sleep disorder that involves the collapse of the upper airways during sleep. 1 out of 4 people are affected, and it has several negative health effects, including the early death. Severity is measured with the apnea-hypopnea index by counting the numbers of apneas and hypopneas during sleep. In most severe cases, we usually treat it with the positive airway pressure therapy. The biggest risk factor is obesity. 58% of the cases are linked to excess weight, therefore weight loss is recommended. The good news, we have some novel pharmacotherapeutic choices for them. I think most of you have already heard about the glucagon-like peptide-1 analogs. These medications can deregulate your appetite, can reduce adipose tissue, while protects against cardiovascular diseases. And the diagram shows how the drug effective was in weight loss. But how they can work in obstructive sleep apnea. We know they can help with weight loss. Furthermore, they can improve the collapsibility of the upper airways and has direct airwave action. The study shows how the drug reduced the severity of the disease, but unfortunately these medications haven't been implemented in the clinical practice yet, so our aim is to investigate that the GLP-1 analogs are effective treatment choices in obstructive sleep apnea. Our clinical question is, can GLP-1 analogs reduce the apnea-hypopnea index, thus leading to improvement in obstructive sleep apnea patients? We work with the PICO framework, and our clinical implication is weight loss therapy with the GLP-1 analogs as a standard of care for patients with obstructive sleep apnea. Here you can see my finalized search key, which we use in 3 different databases, and after the selection we have 5 eligible texts. In my first figure, I can show you the overall apnea-hypopnea index changing among those who are receiving the GLP-1 analogs. 6 randomized control trials were analyzed, including over 500 patients, and the mean difference in apnea-hypopnea index changes is greater than -14, which is statistically significant based on the confidence interval and is clinically highly relevant based on the table below. In the second forest plot, you can see the changes in overall, in the second figure, you can see the changes in apnea-hypopnea index between those who are receiving the GLP-1 analogs and those who are in the control group. 5 randomized control trials were analyzed, including nearly 1,000 patients, and the mean difference was over -11, which is statistically significant and clinically relevant. And in my last forest plot, I want to show you the changes in body weight between those who are receiving the GLP-1 analogs and the control group. In this forest plot, you can see 4 randomized control trials, including over 800 patients, and the mean difference in the body weight changes is over -11 kilograms, which is statistically and clinically significant data. So, our conclusion is GLP-1 analog reduce the body weight and improve sleep-related breathing disorders in patients with obesity-related obstructive sleep apnea, and our implication for practice, use GLP-1 analogs together with the positive airway pressure therapy treatment as an urgent treatment strategy in obstructive sleep apnea patients with excess weight. And our implication for research, we know weight loss has benefits in obesity-related obstructive sleep apnea, but long-term studies are needed to confirm their effects in GLP-1 analogs. More research is needed to assess their use treating mild obstructive sleep apnea. It's also important to determine whether the GLP-1 analog should be used chronically or intermittently, and basic research is needed to clarify their direct and indirect effects. So, we have strengths and limitation. Our biggest strengths, we work with only randomized control trial, which is increase the quality of evidence. Our studies are large and globally conducted, and we do a very broad and comprehensive search. We have some limitation. One of our limitations is the small study number due to the novelty of the topic. We're only able to analyze 2 GLP-1 analogs and the lack of consistent safety data. And as you can see, my manuscript was accepted last Friday in Sleep Medicine Reviews, which is a D1 journal. So we are waiting for publishing. And now I can move on my second project, which is a systematic review and meta-analysis about comparing the effectiveness and safety of positive airway pressure therapies in Pickwickian syndrome. But what is Pickwickian syndrome? Pickwickian syndrome was named after one of Charles Dickens' famous character, Mr. Pickwick, who has some typical features like obesity, sleepiness, snoring, and dropsy. But what it means clinically? In the last few minutes, I talk a lot about the obstructive sleep apnea, but here comes another obesity-related disease, the obesity-hypoventilation syndrome. These patients suffering from obesity, they are hypoventilating and they have daytime hypercapnia and hypoxemia. When a patient has both together, we can call them Pickwickian syndrome patient. Without treatment, they get serious complications like high blood pressure, right-sided heart failure, pulmonary hypertension, depression, anxiety, and fourfold increased mortality risk. So we have to treat it with some positive airway pressure therapies. We usually choose between these two, the CPAP and the BPAP therapy. The CPAP therapy stands for the continuous positive airway pressure therapy. It works with a single set pressure, below the constant pressure when you're breathing in and the same pressure while you're breathing out. Not as great for accommodating in changes in breathing, but more affordable and simpler to use. The BPAP therapy stands for the bilevel positive airway pressure therapy. It works with two distinct pressure settings, below higher pressure while you're breathing in and lower pressure when you're breathing out. Often used to treat more complex sleep and breathing disorders, but it's less affordable and more complex to use, so our aim is to investigate that the CPAP devices are an effective treatment choice in Pickwickian syndrome. So our clinical question is, can CPAP therapy be an effective treatment choice for Pickwickian syndrome patients? Our patient population is Pickwickian syndrome patient with severe obstructive sleep apnea. We want to compare the CPAP with the non-invasive ventilation devices, and our primary outcome is the arterial blood gas parameters, and we have several secondary outcomes. And our clinical implication is CPAP treatment is an effective first-line treatment for patients with Pickwickian syndrome. Here you can see my finalized search key, which we use in 5 different databases, and after the selection, we have 5 eligible full text. In the first full export, you see the changes in morning arterial partial pressure of carbon dioxide in blood gas samples after the CPAP versus the BPAP therapy. 5 studies were analyzed, 2 of them are observational studies, and the remaining 3 are randomized control trials, and the mean difference of the changes is 0.66, which is not clinically significant based on the confidence interval, and it's not clinically relevant. In the next figure, you can see the changes in morning arterial partial pressure of oxygen in blood gas sample after the CPAP versus the BPAP therapy, based on the same studies as the previous one, and the mean difference was minus 0.2, which is also not statistically and it's not clinically significant. And in the last forest plot shows the changes in sleepiness after the CPAP versus the BPAP therapy, and it's overall neither statistically nor clinically significant. So our conclusion, CPAP is an effective therapeutic option for patients with Pickwickian syndrome, and our implication for practice. BPAP is recommended if obesity-hypoventilation syndrome is not associated with severe obstructive sleep apnea. CPAP is primarily recommended in the case of coexisting obesity-hypoventilation syndrome and severe obstructive sleep apnea, and CPAP can offer a less expensive, technically simpler, and more convenient therapy option in Pickwickian syndrome. And our implication for research, we need more comparative randomized trial to optimize the therapy, higher number of patients to reflect the real-life prevalence, and to assess new option if CPAP therapy proves to be unsuccessful. So we have some strengths and limitations again. Our studies work with a clinically important follow-up time, and we do a comprehensive search. But we have some limitation. We find a few studies with relatively small patient population, and other big limitation is the different study type. So here you can see where is my second project progress. All that remains to write my manuscript. And here you can see my previous conference presentation and co-authored publication. And my future plan is continue my work at my university, integrating education, patient care, and research into my daily professional care. And you can meet me in this July in the PhD Scientific Days. So I would like to say thank you for your kind attention with the words of famous physicist George Gamow. Science is not just about knowing things, it's about asking the question and pushing the boundaries of the knowledge. Thank you.
Congratulations on your talk. I wanted to ask you, you said about the GLPs that they work also on the collapsibility of the airway. Do you know if there are GLP-1 receptors there? Because I know that they are in the brain and in the beta cell, in the pancreas, sorry, but I did not heard so far about them.
Yes, so it's what we see in the studies. Some of studies mention they have some receptors in the upper airwaves, but the biggest effects is about of the weight loss, because in this patient who are suffering from obesity, they have some typical fat deposition in the neck and pharyngeal fat and tongue fat. And when they get weight loss, the airwaves getting wider. So it's not a typical direct effect. We have to investigating this if they have a real direct effect, but this is why I show, because I found this study, it's said they have direct effect, but it's mostly indirect effect about the weight loss because it's wider, the airwaves. So this is what we think about this movement. So.
Regarding your first project, implementing GLP-1 analogs indeed a good choice for obstructive sleep apnea patients. But do you know something about the adverse events or complications during the therapy, or were they investigated in the included RCTs?
Okay, thank you for your questions. For what we see, these medication can cause some common side effects. They are mostly gastrointestinal side effect, and this dose dependent, and after the time they are transient. This is the nausea, vomiting, diarrhea, constipation, bloating. They have loss of appetite, they are fatigued and have headache, but this is why they're very effective in weight loss. And we have some serious adverse events like kidney failure, like pancreatitis, gallbladder issues, and they sometimes can be do hypoglycemic periods of the patients. And we have see some rare events like thyroid carcinoma, and they are teratogene, but that we see only in rodents trials, not in humans, and sometimes it can cause like allergy reaction for the injection, but that's all what we see. So, thank you for your question.
Congratulations on a great progress and excellent talk. I would like to ask you about the first project. What was the control group? How was the control group treated in these RCTs?
Yes, so this is what we don't can equality, because as I say, only we have 6 randomized control trial, but in 5 paper, because one of the paper do 2 control trials at the same time. And what we see, 3 of the 6 RCTs are go with the placebo injection. 2 of them are only give oral anti-diabetic drug, and the last one is only give the positive airway pressure therapy for the control group. So it's very different in the standard of care group and the control group, how they treat it. So, but thank you for your question.
Thank you for your excellent presentation. And as far as I understood, the medication is not allowed in the clinical practice in Hungary. Could you explain why? Because recently in Brazil, it was we have a permission to distribute by the government, of course, for the patients with recommendations. So why we are so, how can I say, late?
Okay, so it's not recommended, but we didn't use it. So we don't use this medication. We can prescribe it for especially for type 2 diabetes and for obesity. But for the obesity type of patients, we only prescribed it for no insurance. So it's very expensive drugs. And most of our Hungarian patients are don't really allowed to buy these expensive drugs. So we can't prescribe it for them, but it's not have a medical insurance helping with this financial situation. So this is what we see, and this is why we don't prescribe it for everyone.
The GLPs are kind of new drugs in the market. And you said something about the teratogenic effects. How long were these patients follow up? And is there any safety profile that is different for the patients with sleep apnea compared to the diabetic patients, which we know the safety profile for longer periods?
Okay, for the trials, the follow-up time is very different, but what we see, the shortest one is 3 months, and the longest one is more than 12 months. What we see in the other studies, it's to see the real effects of the drug is at least 6 to 12 months to give the patients these drugs, because if you quit after 1 or 2 months, they get a weight regain, and sometimes it's a bigger weight regain than their weight loss. So this is why it's important to give at least 6 months to, I want to say it's 12 months to give this medication. And what the other questions?
So actually, we have no information about the teratogenic effect of these drugs in patients because 6 months is.
So we don't recommend for pregnant women because of these teratogen effects, but we don't know in human studies. And what we see, we don't have enough safety data to analyze this together. But the studies who are write down the safety parameters, they are likely the same from the type 2 diabetes patients or obesity patients alone, what we see in the obstructive sleep apnea. So these very serious side effects are very rare. The other side effects, it's very common. So the gastrointestinal side effects are very common in this field. But this is why this medication is this effective, because if you are vomiting and nausea, you don't want to eat. So this is what we see.
About these new drugs, have you read any experimental papers where the receptors are, what they can do in the airway and so on? Is there experimental work about that? I don't know. Yeah. And my second question is a clinical one. These type of drugs are used for weight loss. So they make you have a full stomach. And from anesthesia, we know the stomach is quite often full. So how about the risk of aspiration while you do these patients CPAPing? Is there any evidence, any connects? Okay. I as an anesthesiologist, would not ventilate patients with a full stomach. Yeah? Okay. It increased the risk of aspiration.
Okay, for the first question is regarding for the receptors. I only see they find some GLP-1 receptors in the airwaves, so I don't know the details. I'm sorry, it's my bad. For the second question,
this is research to be done.
Yes. This is what I mentioned in the implication for research. We have to dig into this field. And for the second question, if I understand well, these medications are like feel the fullness of the stomach, but it's not a real fullness. So, or I don't know. But what do you want to ask for me?
We do know from people who undergo anesthesia on these drugs. They have a higher risk of aspiration due to the full stomach, and the current recommendation is actually to stop this medication 2 days, 48 hours or 72 hours before undergoing a procedure. And from clinical evidence, we would, as anesthesiologists, prefer to have these patients taking their medication continuously, but fasting for almost 24 hours. This would make sense because the stomach is emptied much slower.
It's very interesting, but can I have a question back? Because some of the medication are not daily regulated injection, like tirzepatide, but the other drugs we use, they are once a weekly injection. So in that case, they skip in the week before the procedure.
Yeah,
okay,
yeah.
That's
and,
interesting.
People actually don't like to stop
I really
this,
like this
because
topic.
the weight gain is immediately. Yeah. So
Yes.
the question of whether to take this intermittently or continuously, I can tell you they want to take it continuously because there is no weight loss if they stop.
My question, when you were talking about the second part of your job, the Pickwick-In syndrome,
Yes.
comparing the BiPAP and the CPAP, why did you do arterial blood sampling? Why didn't you just use end-tidal CO2 or pulse oximetry?
Honestly, because we pop up this question and we do some preliminary research about this topic, and I don't know why, but they have results for the arterial blood gas samples, especially for the morning arterial blood gas samples. So we don't know why they are not investigating in this other type of measurement, right. Because it's less invasive, so it is
definitely
can be better, but I think it's way cheaper, maybe, the arterial blood gas.
Definitely not.
Not?
It's a point of care measurement, and it costs a lot. I mean,
so
I'm not worried about the money. I'm worried about the patient, because an art line is carrying risks.
It's less expensive. I know it's better type, but I don't know why they don't investigating to measure this.
Okay, thank you.
Congratulations for your talk. And first of all, I would like to mention that not just for you, but everybody, that of course the committee knows that you are in anxious state. That's why we will adjust to it when we are waiting for answers and so on. I have a clinical question first and a small statistical question. So you mentioned that if it is stopped early, then it will come back, the weight will go back to the original state. And in my mind, this is the danger also for long term. So I don't know whether it is possible to stop this treatment or not.
Okay, for my answer, it's not only good to use this medication and you don't eat. I think it's the biggest weight loss if you do some lifestyle modification with this drug. So you go to workout, you try to eat healthy, and together you can get a bigger weight loss. And after that, I think if you weigh like 10 or more kilograms, because we have big differences between the two drugs, you can try after 1 year, and for 1 year you eat healthy and work out, not every day, but some days of the week, you try to do this daily practice. And after you stop the drug, you can maintain to get this weight loss in the same position. So this is why the other thing what we recommend to use for up to 12 months. But yes, if you don't do this, you can do the weight regain back. So it's not a solution for everyone.
Okay, I understand. Do you have data related to it? Or there are studies investigating this phenomenon? The long-term effect of stopping
long-term effect, I don't know the exact data, but what I read about, if they stopped and get back on track in the unhealthy lifestyle and stop moving and sport and something, so you get the weight regain, what we see. And I think it's very important to mention for one of the drugs, for the liraglutide, this Saxenda, they write down it's not enough to take this medication. You have to do the calorie deficit and you have to work out. So this is why they are described it in the prescription.
Thank you very much. I understand.
It's important.
It was a like, but for me it's an important question, and thank you for the answer. And then
very important question.
There was mentioning about the difference in the control group, and actually we also saw large heterogeneity. So my question is, how you measured heterogeneity? And there are 2 studies up and 2 studies below that are similar to each other, but the groups are different. Do you have any reason why they can be so different? So try to go back. I think it's easier to one of the forest plot in your first project.
Yes.
For example, is good I think. So my question is how heterogeneity was measured here.
If I know that we use the tool for E-squared test for heterogeneity to measure, and the difference is, I think, it's because the 2 different type of drugs. Because the Malhotra studies use the tirzepatide, and for the last remaining 3 use the liraglutide. And the biggest difference between these 2 medications is the liraglutide is only a GLP-1 analogs. But for the tirzepatide, it's a dual GLP-1, and it's a glucose-dependent insulinotropic polypeptide, so it's a higher effects on the weight loss. So with these drugs, the weight loss is more bigger than the liraglutide group. So this is the most important, is the 2 type of drugs, what I think is caused this bigger heterogeneity.
Any difference in the baseline?
For the baseline, they don't have big difference. They are obese patients who are up to more than 100 kilograms, so
okay, it's good. So I always, your answer was quite correct. We measure it with E-squared, and I like to try to explain the heterogeneity, and you did it. Did you also mention it in your study?
Yes.
This possible?
Yes.
So congratulations. Sorry, if I have time, I don't know. Then it's not statistical question, just again, a like thing that I know. I know that bad sleeping influence weight gain, basically.
Yes,
so
that's true.
Do you have an extra effect in the population you analyzed with GLP? So because they start to sleep better, then maybe it's an extra effect boost.
Yes, we want to investigating in the sleepiness with the effort sleepiness scale, but we don't have enough data, unfortunately. So this is why we only have data of the apnea-hypopnea index, the body weight, and the BMI, what we see, but we want to investigating in the sleepiness.
I mean body mass, so BMI.
Yes.
So it's possible, I think, that GLP-1 result in a larger BMI change due to the fact that it's not just GLP, but also more sleeping. And more sleeping can help to improve weight loss because they can go more easily to gym and so on. So there is any difference in the BMI change in your population to a normal population?
So for how they sleep, we don't have measurements in these studies. So we don't have quality of life data. We only have one of some studies for the sleepiness, because it's important measurement in sleep studies, the sleepiness. This is why I'm talking about, because when you are higher chance to sleep back, it's not a good thing, because these sleeping are fragmented sleeping, and this causes fatigue after you wake up, and you sleep 8 hours, but you feel fatigue.
I understand.
After,
okay,
so.
Thank you very much, and congratulations.
Thank you.